Mycoses. I did post some of the slides, but I think they're repetitive slides. So I just want to encourage you to go and look at the anatomy of skin so that you have an idea as to what are the differences between subcutaneous, cutaneous, and superficial mycosis. And you can read it at your own different layers, and because many are symptoms, the clinical pictures and so on and so forth will basically depend upon the invasion of fungi into deeper layers of skin or mucous membrane, as a matter of fact. Again, to give you an idea, where are those Langerhans cells and what cells are we talking about in terms of melanocytes? You can see these are the melanocytes over here. We talked about hypopigmentation and hyperpigmentation in some forms of mycosis. Okay, today I'm going to continue with subcutaneous fungal infections. And remember, as I said earlier, there are tons of fungi. They're out there, but we will just pick up some of the basic fungi that I think are important for you in terms of microbiology and also in terms of pathogenesis. So always keep that in mind, that as far as objectives are concerned, I want you to obviously know the names of these fungi, the basic structures, and their pathogenesis. So pathogenesis remains as a major thrust for most of the microbiology lectures. And again, I'll just repeat that you have to have a basic concept of immunology to understand how does immune system, especially innate immune system, goes after these kind of fungal infections. So there are 5 different types of subcutaneous fungal infection. Lymphocutaneous, as the name suggests, is going to go for lymph nodes, and cutaneous obviously for the skin. Chromoblastomycosis, eumycotic mycetoma. If you remember, we talked about mycetoma as well, which is a bacterial mycetoma as well. Do you remember the name of bacteria that causes it? Okay. I think there was one person who did a presentation, actinomycosis. Remember, there was one bacteria, we previously used to consider it as a fungi, and later on we found out it was bacteria. We kind of put it back into bacteriology portion of that. I'll come to that in a while. Today I'll just limit myself to the top 3, and we would not do that today. I'll see if I have time. We'll go to the systemic mycosis as well. This will give you an idea that when fungi goes into your system, what are the consequences for that. Okay, again, typical pathogenesis. I don't want to repeat it at all times, but remember the adhesion, penetrations, the cell which are there in terms of innate immunity, the cells which are there in terms of adaptive immunity. The most important thing that you have to realize is that many of these fungal infections are chronic and insidious. And the problem we have is they are refractory to most of the antifungal therapy. That remains a challenge. That's why every other day we come up with new drugs. And we already discussed that, what are the reasons for that. And as far as epidemiology is concerned, one of the first fungi listed in that list was lymphocutaneous sporotrichosis. So sporotrichosis is basically caused by a single fungal pathogen, Sporotrichosis shankai, and this actually will give you a typical clinical syndromes. But remember, as a rule, many of these fungal infections are classified as rare. But if you remember the first slide I showed you, that with the advent of modern surgery, with the advent of treatment for cancer, with immunosuppression, with AIDS, and so on and so forth, we are seeing these type of infections more often than not. So they are there. But all you need to keep in mind is that even if they have a very low pathogenic potential and they are commonly isolated from the environment in which they exist in a different form, especially mold form as compared to yeast form once they go and invade the cell. These are like common themes for most of the fungal infections. But you have to keep in mind that exposure is largely occupational or related to hobbies. People who are gardening, it's also called gardener's disease, especially rose gardener's disease. Those people who are really fond of roses, they actually get these kind of diseases, very common in people in farm area, very common in people, in those areas where there is a lot of decaying wood present and other organic matter is there. Bird dropping, there's another thing, we'll talk about that in a while. But basically these infected patients generally have no underlying immune defect. That's why many a time we talked about the primary pathogens, fungal pathogens that can go after you even if your immune system is patent. Okay, that's a typical classic lymphocutaneous form of sporotrichosis. You can see a chain of subcutaneous nodule along the lymphatic drainage of the arm. So the person just get a prick on the obviously hand and it goes and follows the track of lymphatic drainage. And that's a typical of sporotrichosis and also called Gardner's disease. Classic lymphocutaneous form, cutaneous as well as lymph. Because remember, all the skin is drained by lymphatics and there are draining lymph nodes. What will be the draining lymph nodes for the arm? What's the name of the draining lymph nodes that drain most of the skin of the hand? Axillary lymph nodes. That's why they commonly examine axillary. Upper torso and the whole hand is axillary lymph nodes. Okay, again, sporotrichosis of the leg. Again, you can see extremely rare, but it's a typical lesion you will see, but rose gardener's disease. And many a time it is present for people who actually commercially grow roses. So these are the people who handle the roses, and they get this rare fungal infection that involves the skin, and you can typically see disseminated plaques. You can see disseminated plaques. And it's like a very aggravated forms of that. Difficult to treat, and it has a scaly border. Now, if you remember, we talked about dimorphic fungus. So dimorphic fungus obviously they can exist in different form in environment and can exist in different form once they go and invade us. And then again, apart from inoculation, they actually can disseminate to other sites. So fungi don't really limit themselves to skin or mucous membrane. They can go and even deposit in bones, eyes, lungs, central nervous system, though it's rare, but there are cases, especially if a person is suffering from AIDS, that immune system is such compromised that even central nervous system can also be infected. And you can see from here also pleomorphic yeast grows as a mold at one temperature and another at room temperature. That's the challenge that we have for dimorphic fungi, because many a time the form that cause disease it's difficult to culture it in the same environmental conditions because they're going to exist in two forms. Okay, as far as morphology is concerned, typically dimorphic. If you look at the microscope, they have the typical hyphae, and in this they appear as a rosette form, a daisy petal form. And remember we talked about conidia. Conidia, macroconidia, or microconidia are those little kind of spore-like cells that disperse out into atmosphere, and many people will inhale it. And you can also see, if you were to take a tissue for histopathologic examination, and you'll find a typical yeast form over there. That's what is called, you remember the name of a phase? We talked about two phases for fungi. What are the name of phases? That they exist in one phase when they are in the tissue. Yeah? What is the name of the phase that fungi go through when they exist in environment? Saprobic. So this is like saprobic phase, and once they go into the tissue, this is a parasitic phase. Okay, this is the mold phase of sporotrichs. So you can see typical mold, colorful mold formation. But obviously, as I said, that our bodies would not take the bigger chunk of these fungi, so it's going to go very small, a cell, a unicellular, as compared to multicellular that we get in molds. So they're going to break up into smaller pieces before they are inhaled or deposited or carried away in our lymphatics. Okay, usually in warmer climates, and again is present at a fixed level in quite a few areas. Japan, North and South America, and there's a list of other countries as well. The outbreak of infection are related to, of course, people who are in that occupation. If you happen to work in forest, mining, or gardening, may it be a commercial or your hobby. And then the classic infection is basically a traumatic inoculation. So just like a prick, a thorn prick, that was going to initiate this infection. And then again, there are zoonotic transmission as well, especially armadillo hunters and infected cats. There are reports, especially in Brazil, they talk about cat-transmitted sporotrichosis. That's another thing, but as I said earlier, we would not go in detail as to what are zoonotic transmission of this fungal infection, and we didn't even study that for bacteria and viruses as well. All you need to know is that maybe for veterinary pharmacy, or those people who want to go treatment of animals and so on and so forth, they may want to go in detail as to what are the infections that cause problems in all those domesticated animals. And obviously they are usually checked for all these diseases. They also have all the human diseases that we have, diabetes, hypertension, so on and so forth. Now, the second important thing is lymphocytic sporotrichosis as compared to the one we had, lympho and cutaneous. So this is like a demarcation. It's more of a lymphatic. So the difference, of course, is that usually the site of infection appears as a very small nodule, and then it ulcerates. And remember, this is where the basic, your basic information of anatomy or physiology will come whenever there is an infection. The very first cells which are going to see that microbe are your immune cells, and they will try their best to limit that infection within the area and would not easily permit it to pass to the rest of this of the body in terms of circulation. So this actually appears as a typical nodule, and you will see along the course of lymphatic drainage of the primary lesion. The differential diagnosis is a little bit difficult because many a time they are considered as carcinogenic. So we have some of the malignant cells like squamous cell carcinoma, where there is kind of a very close similarity to this kind of fungal infection and cancer. But obviously you'll do histology to figure that out. Okay, once you have this kind of a lesion, you may want to rule out other diseases like mycobacterial or nocardial infection because they all look alike. Remember, we talked about weeping lesions of tuberculous adenitis or tuberculous ulcers. That also should be excluded if you want to go and diagnose this. Treatment, I don't really expect you to remember the detail. What you need to do is that sometimes we go for the local applications. Many a time we go for the oral antifungal drugs. And as I said earlier as well, many times people are unable to tolerate, because one of the side effects of antifungal drug is hepatotoxicity. So they are very toxic to the cell because the fungi are eukaryotic. So you really have to design a drug that would not cause injury to affected organs, especially those drugs which are cleared by the liver. Many of the drugs are cleared by the liver, so metabolism has important role to play. You can see over here a list of the azole drugs, and you can also see the therapy is usually long, about 3 to 4 weeks. So the patient compliance is a problem because patient will have nausea, vomiting, diarrhea, jaundice. So many people would not comply with that, and they want to give it up. Do you remember there was a type of therapy we discussed, DART therapy, if you remember that? In which bacteria we discussed a therapy, and I said it's important for you to know, it's called DART therapy, D-O-T. Anyone? So you basically directly observe the patient taking a therapy like tuberculosis, because the drugs are so unfriendly and they have a lot of side effects and there's a bunch of them, so many people would not take it. That was the whole idea, that people were sent to sanatoriums and they were sent to the hospital. They want to make sure the nurse or the physician that the patient does take that tablet. So these are some directly observed therapies. And again, this is important for some of the fungal infections as well. The third important is mycotic, and say U is basically a little bit different as compared to bacterial mycosis. Remember that, as I said earlier, there is another mycetoma which is basically bacterial. So you want to make sure that you don't confuse that with this one. This is called actinomycotic mycetoma, but this one is a true fungi. That's why you say U, like eukaryote, U mycotic. So for sure, it's mycotic mycetoma, not an actinomycotic mycetoma. And remember, actinomycosis was one of the bacteria that I said was initially classified as a fungi, but later on put into bacteria. It's very common in the tropic. As a definition, mycetoma is defined as clinically localized chronic granulomatous infectious process. And remember, it could be cutaneous, it could be subcutaneous. The whole idea is that your immune system wants to contain it. It wants to kind of make a kind of, wall against it. You may have it in terms of granuloma, you may have in terms of other chronic inflammatory responses where you have a localized lesion. And we talked about ringworm as well. We talk about, this is another important thing, a mycetoma. By definition, whether it be a eumycotic or actinomycotic, both are mycetomas. And typical scenario will see a multiple granulomas or abscesses. And if you do a biopsy of that, obviously in fungal you see fungi, and in bacteria you see bacteria. So you have to culture it. And many a time in fungal infections you see granules or grains as compared to pus formation that you usually see in bacterial mycetomas. So another important thing you can see, actinomyces for bacteria is aerobic because of the aerobic nature of that bacteria. So it's more of aerobic as compared to fungi. Okay, as far as morphology of the eumycotic mycetomas, they are typical hyphae, smaller in size, and many times you may see black or pale white grains. That actually depends upon which type of that lesion is. So they have a typical deposition of these granules. Epidemiology, basically again typical in tropical areas and more frequent in Africa and Indian subcontinent, but we have in South America, some of the countries do have it. And again, pathogenesis is traumatic percutaneous injury on your exposed parts, so your hands and feet and your body. And foot and hand are most commonly, but it could be anywhere, and men are more often affected than women. Why? Why men are more affected than women in this case? Yes? No? Yeah, Dylan? Because many a time, these are occupational, so men usually are working in, in those fields, occupations, than women. There's no other reason for that. All right, the fungi differ from country to country, and they are WHO classical, but they are not contagious. The mycetomas are not contagious. You can pass it from one person to another. The clinical syndromes, again, typical, and I think all you need to remember is many a time when you have an initial inoculum, you can have a response of the skin, as you have inflammation, redness, swelling, pain, right, temperature, and loss of function. These are the classical cardinal signs of inflammation. But it can also spread via blood to different parts, as we discussed, but many a time it's rare. Many times it's rare. If a person dies with inflammation, infection of the distal organs, it shows compromise in the immunity. Lab diagnosis, you really have to look for those grains, especially if you're going to go for eumycotic mycetomas, and you can also sometimes see a draining sinus or draining tract. What happens is, if, for example, if bone is infected, from bone till the skin, there is a path. There is a path which is kind of releasing those pus or granules. So this is called like a sinus, a connection between outside and the cavity. That's what the definition of sinus is. So you can see that. Many a time you want to do a deep surgical biopsy to pick it up. Treatment, again, no need for you to remember, but remember that they are again azole compounds. They're all azole compounds, and therapy is expensive, very slow. So these are all natural problems with treatment of fungal diseases, and many a time we end up doing a local excision or even amputation. That's the only treatment we have so that we can stop the progression and spread of that fungi into the system. Okay, this is what you can see from here. Chromoblastomycosis of the foot and the leg. So that kind of infection, when it comes, obviously they try to give antifungal drugs, and as I said, very common in India, Africa, South America, and that's where people cannot afford. So unfortunately, they may want to go for amputation. These are some other forms of subcutaneous zygomycosis, which I'm not discussing today. This is going to go jump to systemic mycosis, but you can see problem over here depends upon, there are different types of fungi that are responsible, and even subcutaneous zygomycosis in extremely swollen, very difficult to treat, and there's a lot of time, many times it's indurated. Yeah. I'm sorry? No, this just like, covered. For identification, they just covered the eyes.